Oh, sure. We're good. Are we recording? We are recording. All right. If I could have everybody take their seats. Dr. Newton, I need you, sir. All right, folks, let's go ahead and get started. Our next session is on cannabis and public health. And this particular session is being moderated by Dr. Barton Hershfield. So Dr. Hershfield, I'm going to turn it over to you, sir, and let you introduce the speakers.
Thank you, Gene. Oh, welcome to the next session, which, as Gene said, is on cannabis and public health. I'm Bart Hershfield. I have a solo medical cannabis practice in Southwest Florida, but the reason I'm standing here is because I participate in the Florida Medical Cannabis Physicians Group. It's a group of physicians from throughout the state, totally unrelated practices, but what we share is a core value of providing meaningful cannabinoid education to patients and also making state-of-the-art cannabinoid recommendations to them. We also share the mission of trying to advocate for medical cannabis patients and physicians in the state. Many of the speakers and moderators that you will meet during this conference participate in the group, including today's first speaker. All physicians in the state are invited to join in on the meetings, which are conducted by Zoom. During the meetings, we try to share with each other and support each other, whether knowledge on cannabinoid medicine, issues on practice management issues, inform each other on what's happening legislatively and regulatory. Let's see, if you should get a email invitation to join the meetings. If for some reason you don't, physicians, please see Charles Felix in the exhibit hall and in the Florida or the Cannabis News Florida. He's our executive director, and he will be sure to get you a link. We really hope to see all of you on the meetings, that you'll join us. I really think it's beneficial to all recommending physicians in the state. And the other thing to remember is just like cannabinoids, we're definitely more effective together than we are individually. So hope you'll join us. Okay. Our first speaker, we really could address as Dr. Not only is she a physician, but she has a Ph.D. in molecular and cellular cannabinoid research. From the bench to the bedside, she has been published, referenced, and speaks nationally and internationally on issues related to cannabis, how to use it most effectively. Speaking with us today on public health issues and medical cannabis use, Dr. Sasha Noe.
Thank you so much, Bart. Okay, so 30 years ago, when I decided I was going to grad school and pick a topic, I picked cannabinoid research. It was soon after Dr. Meshulam, as you heard this morning, had discovered anandamide in 2-AG. And so there was so much yet to be known. And I'm so grateful that I made the choices that I did. This is me 22 years ago getting my PhD and flanked by some of, also, we all know Meshulam and these guys, and these are some of the originals as well, Dr. Herman Friedman, Thomas Klein, and they were my mentors. And I'm so grateful to have selected the field of psychoneuroimmunology to complete my PhD work, which I've been grateful to have it go on to be published even throughout the world and as recently as the last few years. So I really find myself super grateful to go from research to medicine. And I truly been gifted with the ability now to take my work from the bench to the bedside. Never did I think I could do that. And I'm thrilled to be able to be in front of you this morning. I'm so thankful for Jean for allowing me to serve in this capacity and educate. And I did put my research in a book because people went, oh, wait, how do you have a PhD in this field that we think is new? And I'm like, well, it's been around for a long time. And we had funding from the National Institutes of Drugs of Abuse. And so it was a blessing to be able to do that work. And so I put it in that book with some case studies. One of the most exciting things for me, not only have I been able to take my work from the bench to the bedside, but I have also been blessed to start at LECOM, Lake Erie College of Osteopathic Medicine, the first of its kind, a master's in molecular cannabinoid therapeutics. And so we are getting to train the next level of researchers in this field. And we are finishing up our first year. Today's actually orientation for our new cohort. We do have a booth out there, and we have a couple of students who are currently in the cohort if you have questions, but I'm so excited to just bring this full circle for me and share it with all of you. So as the only physician we know of in the country that holds a PhD specific in this field for 22 years, it is really my life's goal to educate, consult patients, physicians in the industry so that we can help take patients off of harmful pharmaceuticals and really help them to achieve the highest level of health and wellness as we possibly can in this field. Lots of disclaimers. We are on short time. I'm not going to go through this, but it's up there for you know what we need to have it up for. The top of this, I serve as an expert witness in this field as well, because as you can imagine, the more and more we have issues coming up, this has been quite an interesting time. And I get to consult as well and do conferences and all of these things, academies for physicians. So today is actually the first time I'm probably the least scientific lot. You won't be bored with a bunch of charts on immunology today. But today we're going to talk about a really interesting topic, which is public health considerations that we have. And we're going to talk very, very briefly, due to the limitation on time, on the adolescent brain development, impairment in the workplace, and considerations with regards to impairment with DUI. And we already know where medical cannabis use is in this country. We have a few states still holding out, and we've already heard about the medical conditions that it's extensively able to be used for. And I say this all the time, that we are doing medicine backwards when it comes to cannabinoids and their effectiveness. We know it works. You've heard this morning the historical value of it. And we are working backwards in medicine to be able to help as many patients as we possibly can. However, when it comes to public health, to me, there are really two issues here for public health considerations, right? There is the access for patients to care, appropriate products, safe products. And there's also safety first, not just for our patients, but for our communities. And so as we go through this presentation, keep that in mind. And I want you to consider these questions as we go through the talk, okay? What are the public health considerations for patients, right? We want them to have no limits in access to life and lifestyle factors and not be discriminated against for medical cannabis use. With our patients, we're constantly talking about risk versus benefit for the treatments of their conditions. We want to know what their desired outcome is for health, for vitality, for job security, career security. We want to make sure that they have the opportunity to have safe treatments, modalities for them. We want to educate them, right? We hear about this, and that's a huge part of what I do, is educating as many as will listen on this topic on how we can use this effectively and appropriately. And while we're doing that, we want patients to be able to maintain their functionality, cognitive function as they approach their life. I mean, a lot of times we use these treatments, and as you are well aware, I mean, we use it for sleep and muscle spasticity. Those things can leave us really relaxed and maybe altered. And so we want patients to be able to use the treatments effectively and still function in our daily lives. And we all know in this room, I mean, this is a what I would consider a friendly room in terms of medical cannabis, right? And so you all understand the benefits and how patients can use this effectively and go about their lives. As far as public health considerations for the general public, we really want to think about safety first, right? When it comes to driving, operating heavy machinery in the workplace, cognitive impairment in the workplace, workman's compensation, and situations where we have a drug-free workplace. There are a bunch of physicians in this room, clinicians, people in the industry. And as we all know, there has to be a way for us to be able to get proper policies and procedures in place so that patients can have access to their treatment and not be discriminated against. Okay. And because cannabis can alter your cognitive function, and only because it's Scheduled 1 are we having this major issue. We do know, let's be real, right? There are two sides to every coin. This isn't an answer to everything. It is not, we do have patients who have adverse effects. We do have individuals who use this and maybe engage in activities that it's not safe for people around them. So let's not, let's keep that open mind, because I realize for some of this, some people may go, well, why are you talking about brain development? What is the issue there? And I really want to prompt you to be thinking sort of out of the box. That is who we are, right? We're in a field of alternative medicine. And so naturally we want to think out of the box. And yet at the same time, there are times where I can take Benadryl the next morning I can't function. Right. So let's also be real about, what goes on outside of medical cannabis as well. As physicians, we prescribe medications, whether it's, prescription or over the counter, that can be altering as well. So I feel like, my goal is to bring a balanced set of information every time I get up here and speak, because, it's not an all or nothing. So keep this in mind as we approach this. Common sense isn't always common, right? I like this one that says, this is some quotes, common sense is what tells us the earth is flat. So we also know that while we want people to have common sense, it can also have limitations to the way we think as well. So let's open our minds and let's have an open discussion. I'd love to take questions at the end of this. Brain development. We know that there is a ton of data out there, pros, cons, it's a problem, it's not a problem. And yet what I'd like to prompt you to do is to just really think from a public health and safety mindset here. We all know the benefits to children who have medical conditions that this treatment can benefit. And what I want to ask you to do is just really think for a second. If you're a parent in the room, can you raise your hand? Oh, those of you who are parents, and those of you who have been a kid in this room, raise your hands. Okay. So the reality is this discussion is relevant to all of us. We do know that the brain takes time to develop. And sometimes we see these little slides this one's from the NIH, and it can be very heavily skewed. And there are studies that can probably argue with some of the information here, but it still begs the question, right? Where do we go with this, this treatment or its use, whether it's in it medicinally or for fun in the adolescent population? How do we process this with them, right? And because there is still so much that's unknown about brain development, period. And in this field of cannabinoids, we also want to have a very sober approach to how we advise our patients. I mean, I have patients who have been, single digit ages, patients who have been, in their, 16, 17, 18, 22, whatever, before the brain, as we know, is fully developed. And it's my understanding it's even later now because of the advent of the internet. Apparently, we're getting stupider. So it's taking a little bit longer for that brain to develop. But the point is like, how do we process this in terms of brain development? And I wanted to bring one quick study to light. This is the Association of Cannabis Use During Adolescence with Neurodevelopment, and it was just published in 2021. And they were asking the question about to what extent the use is associated with MRI measured cerebral cortex thickness development during adolescence. And essentially, as we see here, we know that the prefrontal cortex, executive functioning is huge, right? So planning, organization, time management, task initiation, working memory, metacognition, self-control, attention, perseverance, flexibility, all very important. And so if we have any deficits in that part of our brain, it can affect us later on. And this particular study used imaging, and I'm not going to go into a ton of the details. You will have these slides, but suffice it to say it was found that there was some variance in attentional impulsiveness in a 5-year follow-up. And this was a longitudinal study. I mean, there were I think just under 1,000 patients that they followed over a 5-year period of time. So not an easy study. There are some other longitudinal studies out there as well. But it was able to show that there was some transition. It was, the accelerated thinning of, they had the right dorsal medial prefrontal cortex was associated with transition to cannabis use, as well as greater attentional impulsiveness at 5-year follow-up. However, overall, there were no significant associations between cannabis-associated thinning and other psychopathologic and neurocognitive measures at the end of that 5 years. So what do we take away from this? We take away from this the fact that there are unknowns for our children. And so when we, or our, non-adult brain, so when we have a patient in front of us, it still always comes back to that risk benefit discussion, right? You have a patient who's developmentally delayed that has autism and is biting the finger off of their parents, right? We clearly have behavioral issues there that are unsafe, not just for the patient and also for the caregivers, but at the same time, this patient can be helped. Their brain development has clearly been affected, right? And so one might say, well, we're less concerned about what's the state of the brain is than how we can improve this patient's quality of life. And yet in a parent who comes to me with their child who is 8 years old with ADHD and says, I'd like to put my child on cannabis instead of, Adderall or whatever, that makes for a very interesting discussion, right? Do we like those drugs? Absolutely. I don't know anybody that likes those drugs for their children. I don't want my kids. I have 2 kids now, they're adults. I don't want my kids on pharmaceuticals if we can avoid it. There are times where it's appropriate. And yet, to me, I reach for lifestyle changes, nutritional changes, a lot of other things before I would even want to put my child on a stimulant for ADHD. And I'm not please don't walk away with any blanket statements. Nothing that I say is ever blanket, but understand this is kind of where we need to come from when it comes to patient care as we consider what's best for our children. There is no black and white. Okay, the days are gone. I grew up in the say no to drugs era. This is your brain on drugs. And when I started research in this field, it was implied that cannabinoids were purely negative. I mean, we had funding for cannabis, cocaine, opioids. So it was an implication that there was all this negativity. And we do know that there are some downsides, but overall, I think the benefits far outweigh the downsides. So as we think about the underdeveloped brain, I think that's what we need to walk away from. Okay. And so that just reiterates the last slide for the significance of time. This is off the normal website. The other thing I hear too is, oh my gosh, we're going to have all the kids using pot now that it's legal. And actually, we have data that shows that its use has gone down over time since 2021 as measured here. 8th graders are down to 7.1% from 11.4. 10th grader use 17% down from 28. 12th graders 30% down from 35. And you can question all you want. You question the data, and that's good. I'm a scientist. Let's question the data, right? At the end of the day, though, we're really not seeing that. Is it equivalent to the fact that, they have access and now it's less appealing? I don't know. Okay. And so these are all things that have to prompt us to think about, like, don't make these statements based off of fear, like it's more accessible, so everybody's going to be using it. Not necessarily true. Okay. So that's my prompt, is to have you keep that in mind in terms of brain development in children. In terms of impairment in the workplace, first, let me say this. We have a ton of money in our economy that gets lost from individuals who miss work due to chronic conditions. So first and foremost, I want to say there's a tremendous opportunity with medical cannabis to help individuals in the workplace, okay? The flip side of that, though, right, is that when patients are using medical cannabis, now we have companies where it's a drug-free workplace. I mean, I'm in healthcare. I remember having a nurse practitioner from a big health system come to me. She has a pretty significant medical condition, scared of using medical cannabis because she can get randomly drug tested and lose her job. How many are physicians in this room? Clinicians? Oh, wow, wow, wow. Right. And so the idea is that we're in a field where we are meant to make sure we're taking care of our patients and we have our full cognitive function, right? But medical cannabis is not the stepchild in this, right? As I said, there are days I wake up after I take Benadryl, I'm like, holy cow, I need to get my brain working properly, get that fog out before I can get into that room with my patients. And so It is a real issue, though. If you're in an employed physician in a system and they drug test you, now we have a real issue on our hands. And I want to personally share, 9 minutes, personally share a story. So I almost died in 2016 from getting my gallbladder out. I had a bowel peritonitis. As you all know, as physicians in medicine, we don't know how to treat that. It was hell. Okay, talk about praying to die because you're in so much pain. A couple years later, I had to go and have some adhesions fixed because of that. And I chose to become a medical cannabis patient in the state of Florida because I refused, when this first happened, I refused to use narcotics. I was in pain constantly till over time the pain subsided because narcotics permanently change your brain. We know this. But I became a medical cannabis patient because I did not want to use narcotics to get over the pain of the correction of that surgery, those adhesions, right? And I was good. In 3 days, I'm good. Like no narcotics, I feel great. So my point is that I took that risk as a physician to become a patient, and I'm standing in front of a room of people and, I'm not going to wish it on myself, but, I dare someone to come and have an issue with me for that, because tell me why I cannot use medical cannabis to treat my post-surgical pain. Tell me. Okay. Because if you think my brain is better off on opioids the next day, I would have a serious discussion with you about that. So to think that these approved prescription medications are free of issues were, it's a bit of ignorance actually. So, and I realize it's a risk. Somebody will be like, oh my gosh, she's a patient. I don't care because I know the benefits of this drug and I'm an advocate for it, not just for my patients, but for people in my profession. And I look forward to that changing. Maybe changing the slide to start. Okay. So, there's this issue like, okay, so patients, can they use their medical cannabis while they're on breaks or not? Companies are having to really think about this because it's a real issue. We don't want someone altered. And I understand the source of that is safety of the workplace, safety of our coworkers, safety of our patients and our clients. But these are real issues that we have to understand and answer. Workman's comp, if somebody gets a workman's comp and they're a medical cannabis patient, are they able to get their medications paid for? We know the cost of this. We know it's very high. It's not covered by insurance. So there are several states that have taken stands on this, and you will have access to the slides so you can see where they are. But at the end of the day, we really have to ask, how is it impacting safety on the job? Okay. Can an employee file a discrimination lawsuit? Okay. If it doesn't align with the company's drug policy, how is it affecting the bottom line? And what does a defensible drug policy look like today? Challenges, guys. These are not simple. As Bart mentioned, as part of the legislative group, we delve into these complicated subjects all the time. It's not that easy, but it's necessary. And it's only going to be even more necessary. We have Supreme Courts that have addressed the issue that said, yes, you can. And here are some of the states listed here: New Hampshire, New Jersey, et cetera. You can read about that. But if that's you in your state and you have an issue about that, read about it. I apologize for the slide. I thought it would project better, but the concept is, take away from this is that impairment can happen for a lot of reasons, not just medical cannabis. Impairment can happen because I didn't get enough sleep. I was just joking. I just traveled for 2 days and I'm like exhausted. I had 3 hours of sleep last night after traveling 2 days on a plane. Okay. Is my brain impaired? I stand before you this morning to go, yeah, this is probably not my best presentation in the world because it's a little tiring, but can I still stand up here and educate you guys? Of course. Right. And so we have impairments that can show up in many forms. And at the same time, it's up to us in the workplace to address this issue. How many of you own your own businesses in here? Okay. And how many of you face this in your own businesses that you own? Right. So, we really do have to consider that. How can we best provide access, not discriminate against our patients, and still protect everyone else that's involved? I find it to be an opportunity. Okay, it's not a negative thing. It's an opportunity for us to grow, an opportunity for us to learn. Let's figure out what can work so we can have a solution. As far as DUI and medical cannabis use, all right. So this is the fun one, right? We don't have a test for this, right? We don't have one particular test that you get pulled over by the cops and they can say, you are high on medical cannabis. They might smell it in your car. You produce your card, whatever, but that does not mean that you are impaired. Okay. And so it is on us and us as a society to come up with a plan. This gentleman here is in Pennsylvania. He's a lawmaker in Pennsylvania, and he decided to put himself out there and say, okay, I'm going to get tested. Okay. He uses it for sleep, a tincture for sleep. And he's like, look, I wake up wide-eyed and bushy-tailed the next day. I don't have a problem. Okay. But then there are people in law enforcement that say this. If they have taken it within 24 hours, they're still impaired. Excuse me? Here's an opportunity to educate, right? And it's interesting to me when I run into law enforcement and I tell them what they do, they kind of like, I don't think they know what to do with me, because I'm like, no, let me help you understand how this works. You know, they just know what they know and they don't know what else to do with it. And this is the wrong perception. You can use, you know, cannabis and not be impaired in less than 24 hours. Okay. Or we wouldn't be using it effectively for patients for sleep who turn around and run these massive companies the next day perfectly fine and better off than taking some of the sleep aids like, you know, Zolpidem and Trazodone and all this other stuff that really lingers. Okay. So I really think that, you know, the goal is to find a solution for us. We have it for alcohol. It's coming for cannabis. I wanted to just show you a couple of options here. This, I have no dog in this hunt, just so you know. I just wanted to bring the information to you, but there are a couple of options here. This one is called the Hound, and it's an opportunity for them to be able to detect THC before it gets metabolized. So the idea is that you would utilize this and maybe be able to tell if someone had recent use. And of course, stack that with whatever other information you have in terms of, is that person really impaired or not? It's more than just, is it positive? Do they show signs of impairment? But you can read more about this. They really are, you know, they're out there, they're selling this product. And, you know, has anyone used it or familiar with it? I was not familiar with it. So, I mean, it's an interesting one to look at. But a couple of years ago, we had, so here's a little bit more information. 2 minutes. Handheld Hound device for you hold it for 2 minutes. It acts like a mini mass spec, which is super cool, right? And so it just gives you an idea if they're finding unmetabolized THC, and if they consumed it within 2 to 3 hours prior to testing. So, you know, some value there. I would tell you in the expert witness world, this is a very hot topic right now because we are having issues come up with people being questioned about if they're a medical cannabis patient, various issues that come up. But we know, like for employees, unions, legislators, drivers, advocates, all of this, we have all these patients that are using medical cannabis, and this is a very serious thing that needs to be addressed. There's a breathalyzer that scientists started to work on. This one's a little bit different, more complicated, but at UCLA, they developed this breathalyzer test, and it actually shows up in a form like this. And it's using phenol. I mean, this is chemistry, you know, was not my thing. I know it's Dr. Block's thing, but, you know, it gets into the whole chemistry of this and the opportunity to be able to also find whether THC is available or detected. There are a million questions for us to ask, right? Impairment isn't just a positive test. It's also everything else that goes along with it. Is it blood? Is it urine? Where we're finding it, and what is exactly does that mean? So I wanted to bring that to your attention. This is not an exhaustive presentation. There are things in terms of public health that we have to be aware of in terms of advertising, product labeling and safety testing, education. We want to meet the learning styles of all of our different patients who use different treatments, including edibles, and how to read COAs. I mean, I hope physicians even understand how to use COAs. We have patients in ALFs and nursing homes that need to be protected and treated as well. And how do we help them in terms of making sure they're safe? Employment protections is huge. Organ donor list, child protective services. If you're a parent who, you know, is using cannabis, medical cannabis, that could become an issue, whether it's relevant or not, where it's applicable. So I think there are lots of issues that we do have to address with this. And I know this is a very short presentation, so I did want to leave some time for some questions. A couple of pictures from Fiji. I just came back from their beautiful place. The one in the middle is me jumping off of a 60-foot pole towards a trapeze that I know I wouldn't reach, but you know what? It was amazing going for it. And I'm so grateful that I got to experience the beauty and stillness of Fiji. But I will take some questions for you. Here's my contact information. If you want to reach out, would love to talk to you. Thank you. Any questions?
No, at the end.
No, questions later. I take that back. Next.
Thank you, Dr. No. I think to keep us on schedule, we'll save questions to the end if we have time. And if we don't have time, I'm sure the panelists be happy to stick around, afterwards to answer your individual questions. All right, our next speaker is board certified in anesthesiology, is fellowship trained in interventional pain management, and earned certification in addiction medicine. He is an advocate and educator for medical cannabis and currently serves as the Florida Medical Director for Trulieve. Speaking to us on medical cannabis, is there potential to help replace opioids for patients with various causes of non-malignant chronic pain? Dr. Terel Newton.
Left out one thing. I'm the son to that lady right there. Can you stand up, Mom? Can you stand up? Well, so my mom is a nurse. She's been a nurse most of my life, and that was my first healthcare teacher. And then Dr. No was my first cannabis teacher. So for all the politicians in there, I feel like I'm following Martin Luther King after his speech. And for all the sports fans, I feel like I'm coming in as a sub for Michael Jordan, to give you some context. All right. I look at myself as a teacher. I mean, I have all these different roles, but I'm an educator. And I'm used to walking around. I would love to walk around, but I know for this purpose of this recording, I have to stay here in place. But I do want to poll the audience. So I like that interactive feeling. So here and there, I may ask you to raise your hands. I may ask you to repeat a number. My dad used to say, experience is the best teacher. And I feel like repetition is the second best teacher. So some of these themes that I'll be talking about, you'll see them recurring, and they're repeated on purpose to help us get more skilled and to become better recommending physicians, better educators, better providers, better advocates. So when I was doing recommendations here in Florida, and by the way, it was much different from Vermont, where their patients can get the medicine for any condition that the provider deems medically necessary. So we have naturopathic specialists recommending cannabis there. We have nurse practitioners recommending cannabis there. We have physician assistants recommending cannabis there for a list of conditions, but then any other condition that the provider deemed medically necessary. So I have a point of view of that. And then here, learning process, it was almost like building on that knowledge. And I learned a lot from the patients in both states, and there's different types of ways to treat a patient properly. So one thing I want to give you an idea about when I go over the research is that how many types of cannabis there are. And even if the bottle is labeled 300 milligrams, there could be 5 different types of bottles, all labeled 300 milligrams, and there'd be different medicines in all 3 of those bottles. And you're within the regulatory framework of your state. And so I think Gene mentioned that tomorrow morning I'll be giving a presentation on cannabis dosing, and just to help us increase that skill set. So it took me about 2 years of recommending cannabis here in Florida to a point where I felt like I can specifically recommend certain terpenes for this type of cancer versus another type of cancer, or I can specifically recommend different cannabinoids for this type of neuropathic pain versus another type. For example, if we have a patient dealing with neuropathic pain from a traumatic spinal cord injury, the nature of that and pathology is very different from somebody that has neuropathic pain from diabetes, for example. All right, so I'll go ahead and get into it. We'll go through these slides. So I have some disclaimers and disclosures. A lot of the medicines are not FDA approved. Some of them are. And as you mentioned, I am the medical director of the dispensary, so there may be a conflict of interest. I also have some research projects that I've done with other medical schools, and none of that which will be discussed today. And the learning objectives are really to explain the relevance of this topic today, and also tell you about the effectiveness of cannabis. And we want to find out where it's not effective, and we want to find out where it is. And so we can gain a lot of knowledge, even in studies that show it doesn't work. Which, by the way, most of the studies show that it does, but just in case you're looking at a study and it says that it doesn't help the patient, further analyze the study and to try to decipher why it hadn't helped the patient. So looking at this, I wanted to let everyone know there's more to the opioid epidemic than is on the surface. So I want everybody to say 3 waves. Say 3 waves. 3 waves. Okay. So there's 3 waves of increases in deaths. So the first wave is prescriptions. That was in 2000. The second wave is heroin. That's that middle one there, about 2010. And we're in the third wave now, which is the synthetic opiates. Has anybody heard of fentanyl? Okay, so a lot of the fentanyl on the streets has not been prescribed. It's through the illicit market. So if you think of a meth lab, now think of a fentanyl lab. So that's where it's coming from. Has anyone heard of carfentanil? Raise your hand if you heard of carfentanil. So fentanyl is 100 times stronger than morphine. Carfentanil is 100 times stronger than fentanyl. So that's not, as far as I know, a medicine prescribed or recommended in any country, to my knowledge. It's definitely not here in the US. So that's 10,000 times stronger than morphine. So 1 milligram of carfentanil is about 10,000 milligrams of morphine. So about 187 people die every day from an opioid overdose. So I'm just going to round that up to 200. Everybody say 200. 200. So if you were here this time tomorrow, and then you're here now, about 200 people died from the opioid epidemic. But let's look at further. I'm not even going to break it down by male, females. That's so controversial nowadays, but 20% of people deal with chronic pain. And in our state, that's much higher because we're, a lot of our population here is of retirement age. And so as we increase in age, we become more at risk of having chronic pain. Now, keep in mind, we have another whole list of conditions that's listed there. And if you look at the Florida statute, you'll see chronic pain is listed last on the list. But that is a blessing because it allows patients like sickle cell to access cannabis. It allows patients that have spinal cord injury, even though it's not specifically listed, because they have pain, they qualify. It allows patients that have traumatic brain injuries, even though it's not listed, they have pain, they qualify. So we can think outside the box, more or less, when we think about chronic pain. So this is something I found very interesting, and I'd like you all to say hospital admissions.
Hospital admissions.
So I had a patient in my Jacksonville office that took some CBD gummies given to him by a friend. About 30 minutes later, and he was at home, 30 minutes later, he felt a little drowsy. About 45 minutes later, he felt like sleepy, and he went unconscious about an hour later. He stopped breathing. So emergency medicine services had to be called. He was intubated, taken to the ER. And guess what he had in his system? Fentanyl. So he took a CBD gummy in his Ziploc bag. So that is a hospital admission. So I want to open our minds, and it's not just about deaths. What about the patients that are near death? So when we look at this graph, this top line, that dotted line, shows the opioid medicine sales. This isn't even the illicit market. This is just the sales of prescriptions. And then that line below that, that's the deaths. And then that third line, the dashed line, that is the hospital admissions. So imagine combining those two bottom lines together and how high that height would be. You combine those, and it included the hospital admissions and the opioid-related deaths. And keep in mind that in a lot of cases, the fentanyl is put in the cannabis to make it stronger, make it more addictive, so that way when you stop, you start to feel withdrawal symptoms. And make it stronger, it's a better pain reliever. But when we think about addiction and we think about cannabis, what is in that illicit cannabis that the patient is taking? Why are they really addicted to that? So now they have withdrawal symptoms. So now they get classified as having a cannabis addiction, which, by the way, we should check and double check our ICD-10 codes. When we have a patient getting cannabis for medical purpose, it's not a cannabis use disorder. So double check the ICD-10 code if you use ICD-10 in your EMR. So another reason why this is relevant today is because more and more options and different formulations of cannabis are becoming available in different states. And if we look at a map here, we see some states have passed different rules and regulations, but they're not operational. Some have passed it and they are operational. And then there's even medical CBD. So, and I want to clarify, medical CBD is not hemp. So everybody say 17. So in Georgia, they have 5% THC is available. What is hemp? 0.3%, correct? So 5% is 17 times 0.3%. So it's not medical hemp. It's not medical CBD, what they have in Georgia now. The other thing I wanted to clarify is sometimes a law passes, but it's not implemented. In Virginia, they have passed recreational use, but it's not, that was in 2021, but it's not going to be implemented until 2024. Virginia is unique in that they have any condition that the provider deemed medically necessary. Some states don't have a specific list. Georgia has a list of 17. We have our list is 13. You look at places like, let's say Colorado that has medical and recreational. A lot of the patients are going under recreational, but they're taking it for a medical use. So we need to think about these statistics and really analyze them. And let's say theoretically that we have recreational available here in Florida next year or the year after. A lot of those patients will be under recreational, but they're taking it for a medical purpose. Some patients can't afford to get their cards. Some patients are on a budget. They have difficulty, breast cancer, other cancer treatments that are very expensive. They want to take it for the nausea, they want to take it for the pain, but they can't afford to see another doctor for a separate purpose. So they go under recreational. And then you have a group of people that, you know, say 17 again.
17.
Okay, so about 17% of what we call recreational or social opportunists, I would say. So they have some PTSD, but it's not bothering them enough to get their card. So let's say they might have PTSD from a plane almost crashed one time when they were flying back to Vermont because it does snow a lot there. So that's one example where you have someone called a social opportunist. I have this medical condition, but it doesn't bother me all the time. So maybe I didn't get my card yet, but when it becomes recreational, some of those people will fall into that category, or they may go ahead and get their card just as a backup. So let's take a look here. I just want to make sure I'm staying on time here. So I did some analyzing of data for medical cannabis for neuropathic pain, fibromyalgia, and migraines. And what you'll find is that the actual medicine that has been studied is very variable. So I'm gonna present the same information, but I'm gonna present it two different ways. So this is just one of the tables that is actually from the research studies, and I consolidated it. And I want to point out a couple things. Let's see if I can bring the pointer here. So here we have, if we're just looking at the medicines that have been studied, we have medical cannabis. By the way, it's not defined as how much THC, how much CBD is here. We have nabiximols, which, has anybody heard of Sativex? Sativex, okay, so that's 27 milligram of THC and 25 of CBD, and it's usually dosed as 2.5 milligram of THC and 2.7 milligram of THC and 2.5 of CBD per unit, per dose. And then we have, let's see down here, Nabilone. Has anybody heard of Nabilone? The other name is Sesament. So that's basically a THC analog. So that is 1 milligram. And then we have, has anybody heard of dronabinol? Is that FDA approved? Yep, since when? Since about 1985, somewhere around there, or earlier. So my point is that there's heterogeneity among the different types of medicines that's being studied. And if we can get more studies where we actually have a certificate of lab analysis, like what is required for all of the medical marijuana treatment centers for every product, then we can get more specific and get more detail on these different medicines that we're studying for neuropathic pain, fibromyalgia, and migraines. This is another way to represent the same information. And the way to look at this is the green represents the various medicines. So just look at the length of the bar. Don't even look at what's in it. Sorry, let me go back. All right, don't read the actual name, but just look at the bar, right? So here we have a study that's, maybe like one or two medicines, and then look at this. That's a lot more medicines that's being studied. This is a lot more medicines, this is a lot more medicines. So there's a lot of heterogeneity in there. For those visual learners, some people learn with colors, and so I wanted to have another display that was in colors. And then look at these descriptions. So these descriptions are, and I'll read you just a few of them. So these are some of the conclusions of cannabis for neuropathic pain. It provides short-term relief. There was this statistically significant benefit. There was some weak recommendations on it being beneficial, and it said it can be considered. And another study said the risk might outweigh the benefit. Now, keep in mind, this is one of the most difficult conditions to treat in the neurologic world, in the pain world, is neuropathic pain, because you're directly damaging what sends the pain signal. So by comparison, the other two conditions that I will cover are much easier to treat. So regardless of whether we're treating neuropathic pain, we're treating spinal cord injury patient, we're treating fibromyalgia or migraines, we want to be very systematic in our approach and discussions with our patients. So this is a 6-step approach that which we all take every day. Some things we spend more time discussing with the patient if they're not knowledgeable about cannabis. Some things we spend less time talking to the patient. So we start with a comprehensive clinical evaluation, getting the medical and psychosocial history, including allergies, medications, weight. And we discuss multimodal treatment first. So for example, if a patient has severe back pain and sciatica from a disc herniation, they may undergo chiropractic therapy, physical therapy, home exercise, activity modification. You may, take them off of full duty at work for a period of time. You may prescribe anti-inflammatories, prednisone, Tylenol, ibuprofen, naproxen. You may prescribe muscle relaxants. So this is multimodal treatment. So it's like bringing in the Army, bringing in the Navy, bringing in, the different modalities of care. And then you consider a trial of cannabis if that initial multimodal therapy hasn't helped. And one of the most important things is this next thing, which is called shared. Say shared. Shared decision-making. So we're going to decide together. I'm not going to tell you, you're not going to tell me, we're going to share in the education. And another reason this is important, because some patients have taken it and smoked cannabis for relief, but they may not know that there may be a better route. Has anybody heard of sickle cell disease? What if you have a patient that is coming from a state like Colorado where they can smoke cannabis? However, there might be a better route because there's a type that doesn't increase your carbon monoxide levels. There might be a better route to where the medicine lasts longer. There might be a better route to where you absorb more. There might be a better route to where you don't feel jittery at night. There might be a better type. It might be a better dose. There's so many different options with cannabis that we need to do that shared decision-making, even when a patient has had years of experience with the medicine. So we want to talk about an initial, phase or trial treatment, and then we want to follow up. And the long-term thing we want to look at is, and this is, in this particular study, they mentioned, 12 weeks. You can follow up earlier. If you have a cancer patient, a terminal cancer patient, you don't have to just give a recommendation and not see them for 6 months or 7 months. You can still follow up with that patient in a week, in 2 weeks, in 3 weeks. So while these are guidelines, they don't dictate how you deliver care for your patient. If you know it's a more complex patient, don't make them wait 6 months for a reevaluation. Some patients, you may not want them to wait 1 month for a reevaluation, but have some type of follow-up. I'm not saying you have to see them in the office. Thankfully, with telemedicine, it makes it much easier than when I was doing the recommendations as far as your follow-up. So fibromyalgia, as I mentioned, that was the most difficult one to treat. So some of these concepts are going to be repetitious. Some will be new to you. The first thing I want to mention to you is that one of the mechanisms of fibromyalgia is which is widespread muscle pain, fatigue, insomnia, problems with memory, and mood. Someone say problems with mood. So we can't forget that our pain patients are going through an unpleasant sensory and emotional experience. So we want to try to address both problems simultaneously. One thing I found very interesting about fibromyalgia is that one of the mechanisms is an endocannabinoid system deficiency. So the patient's body is low in their own endocannabinoids. So we're helping them supplement that with the phytocannabinoids. And you will be very amazed at how well patients do with cannabis. And you'll be very amazed at how well they do with different types. Some patients get dramatic results with CBD. Some get dramatic results with a 1-to-1. Some get dramatic results with a 1-to-20. Some get dramatic results with a 20-to-1. Some get dramatic results with primarily THC. And with fibromyalgia and migraines being related to endocannabinoid system deficiencies, it becomes one of the miracles. And where you hear about a miracle drug, this is where, if there was one, this is how you would define it, as you're replacing something that the body's deficient in. And I mentioned in the beginning, imagine 5 different medicines that say 300 milligrams on a bottle, and they're all different. That's one situation where there's 5 correct ways to address that patient. But we always do it as starting low and going slow. I want to go to migraines. And I remember the first time I had a migraine, I was at ECU. I was in undergraduate school there. I was getting off the bus and I saw this thing that looked like, has anybody seen the Predator movie? Do you remember the camouflage that he had? So I had this camouflage. I'm an undergrad, so I don't know anything about medicine. I don't know what a migraine is either. I see this camouflage as I'm getting on the bus. It's like this whole visual field here. And I didn't think nothing of it because I didn't feel anything. And so I got on the bus. I started feeling a little nauseous. So I caught the bus to the parking lot and I was going to drive home. And I felt like I was hit with a baseball bat in the side of my head. Somebody say baseball bat. So I couldn't leave the parking lot for about 2 hours. I was in such severe pain. I couldn't leave the parking lot. At this time, I was a supplemental instructor in organic chemistry, and had this severe headache. Didn't know what was going on. I tried to go to sleep in the car. I think I might have fell asleep. Next thing I know, the parking lot is empty. I'm still there. But the parking lot was full when I went into my car. But by the time I woke up and left, the parking lot was empty. It was at night. So thank God for sleep. But migraines is another one of those conditions that can be associated. One of the mechanisms, I'm not saying all the mechanisms, one is an endocannabinoid system deficiency. And if we, again, replace the endocannabinoids with let's say the endocannabinoids are low and we're giving them, it starts with a P. Phytocannabinoids, we can get dramatic results. And what you'll see here is a few studies, and they're quite different in the type of medicine that the patient received, but they're very much the same in the outcome and the success rate. So this first study here was where the patients received 200 milligrams of THC that effectively reduced the intensity of migraine by 55% in that study trial. Now that's a lot to start a patient on. So what I wish they had explained is what was the patient's previous experience with cannabis. All it was at that time, they were taking 200 milligrams in the study. I don't know if they worked them up to 200 or exactly how, but it was 55%. And in the pain world, that's success. 86%, this is another study, 86% reported reduction in symptoms. And another study where patients took, actually in the smokable form, they reported increased quality of life and pain relief, and they reported taking the medicine 1 to 10 hits per day. And in some patients divided that as 2 to 3 times per day. All right, so I got 1 minute left. So I have to close here. All right, so in conclusion, there's a lot of different preparations of cannabis that has been studied. And we need to dive into it deep if we're using a study to guide our recommendations. We want to consider that neuropathic pain, which is one of the hardest to treat symptoms or conditions overall in the pain world, we can be successful with that. And there's something in the 6 steps that mentions monitoring activity and analgesia, but also monitoring aberrant behavior and adverse effects. For fibromyalgia, the majority of studies show that the benefits outweigh the risks, as well as for migraines. There is a need for further research so we can define, okay, what types of medical cannabis help best with this type of neuropathic pain? What types of medical cannabis help best with fibromyalgia and migraines? And always review your state laws and definitely consult with an experienced provider to get the best, most specific recommendation for you.
Our final speaker this morning comes to us from New Jersey, where he is on the teaching faculty at JFK Medical Center and is an associate attending staff physician in the Department of Medicine at Raritan Medical Center. In addition to being very involved in cannabinoid medicine throughout his career, he has strived to bring together Eastern and Western medicine. He not only educates patients through his practice, but also through the media as the host of Ask the Doctor on WCTC Radio in New Jersey, as the medical correspondent for Cablevision News 12 in New Jersey, and also as their host of Health Matters. He has appeared on CNN, Extra, and Larry King, educating us today on cannabis and the heart. Beware, Dr. Derrick DeSilva.
Thank you very much. Pleasure to be here. A special thank you to Jean for putting this conference together and allowing me the opportunity to share some information with you. So let's get into immediately some statistics. Heart disease is still the #1 killer in this country, folks. Every 32 seconds, somebody has a heart attack. 600,000 people die of heart disease every single year. But we have a whole bunch of new drugs. Are they working? No. Are the statins working? No. Somebody goes into the hospital, and I'm with the residents and medical students all the time. They go into the hospital and they come out with what? A statin, a beta blocker, an ACE inhibitor, and a blood thinner. And they go home and they say, I feel terrible. What are we doing for their quality of life? So we really haven't made any differences in these folks' lives. It is still the #1 killer. What are the options? What are the alternatives? What I have been talking about for the past 35 years is the integration of Eastern and Western medicine, folks. It has to be done. It has to be done. We cannot keep doing what we are doing because it is not working. That is the definition of stupidity. And we are continuing to be extremely stupid. I will warn you here. Some of you may not like some of the data that I'm presenting. You may not like this, but it's the reality. Every single one of my slides has a reference in it. So again, just education, knowledge, beware. Frequent cannabis use, specifically marijuana, among young people has increased the risk of stroke, and it has increased the risk of arrhythmias. Now, the arrhythmia issue is a little bit controversial, and I'll get into that in just a little bit. People who used marijuana, 1/3 more likely to develop coronary artery disease. So when I started preparing for this, the reason I got interested in this is because there was a Medscape article where and I love to read EKGs. I'm an internist, so traditional internal medicine training. One of the big jokes that we always had was, let's get a cardiogram and let's show it to 3 cardiologists that come onto the floor. Back then, we did not have interpretations on the EKGs. And guess what? we would get 3 different interpretations of the same EKG. So I always said to myself, I'm going to learn how to read these babies because I want to interpret my own EKG. So my question, and this is what the Medscape article was, the Medscape article showed an arrhythmia, gave a brief history, and asked what was the diagnosis. And, you know, I like to play with these, so I read through it, and it was essentially a frequent cannabis user had this specific arrhythmia. And this got me really interested because I've been doing this for a little while, and I've never really seen this. Well, had I not seen it because I wasn't looking for it, or had I just didn't even know what this was? So this is what really sparked my interest in this whole thing. And what they found, and this was a Stanford article, paper, was this was a dose-related response. The more frequently somebody uses cannabis, the greater the chances of this happening. But again, it comes back to why. What is happening in the vasculature that is triggering this type of phenomenon, physiologic effect happening? So daily cannabis users were 34% more likely to have coronary artery disease than those who have never used marijuana. Monthly cannabis use was not associated with significant increased risk of coronary artery disease. And this was adjusted with tobacco use and alcohol use. And we're having, and by the way, we're hearing more and more about alcohol use with regard to disease in general. You know, we've always thought that alcohol was, in low doses, was relatively benign. But how many people actually have 1 glass of wine? I mean, if you're Italian, a glass of wine is a bottle. You know, and it's just the way it is. You know, if you're French, a glass of wine is probably a bottle and a half. But that's the reality of what's going on. So let's also start paying attention to some of those other risk factors. But here is what really triggered my interest. There is an inflammatory response that is happening specifically with people who what? The use of how cannabis is used. What do you think is triggering this response? Is it a gummy? Is it smoking? Is it what is triggering that inflammatory response? What do you think it is? Sorry? Right. But which is more, absolutely, there's a cytokine response with this whole thing. But are you going to have a greater inflammatory response if you smoke or if you use a gummy? Smoking. This is why I got really interested in this, because what this is doing is, are there other components within the cannabis? We know that it has an anti-inflammatory response, right? That we know. But what is it that is producing the inflammation? What is it? Are there other chemicals involved? Is it too much? I don't know that we really know the answer. What we do know is that it does produce an inflammatory response that we start to see. So I'm going to go back to work that I started doing 15 years ago. 15 years ago, and by the way, the gentleman that looked at this data, at this literature, this is called and I'll point this out to you. So this is the endothelial layer right here. The endothelial layer is a single-celled layer that looks like shingles on a roof. If that endothelial layer is intact, water cannot get through and damage your home. As soon as that endothelial layer loses that ability to keep the water out, the damage gets done to the house. That endothelial layer, that shingle on your roof is also protected by this layer here. This is a microscopic gel-like layer that is composed of peptidoglycans, aminoglycans, glycoaminoglycans. These are complex sugars. The gentleman that found this, he is from the Netherlands. He is going to win a Nobel Prize in medicine. And I said to him, Hans, I need my name on one paper of yours because you're going to win a Nobel Prize. And I'm convinced of that. And I know he is, because this layer is a layer that was really not seen because we were studying the endothelium in vitro versus in vivo. Because as soon as you take this out, it's like a fish out of water, right? When that fish is in water, it immediately comes out. It's very slippery. It's very gooey. As soon as you take it out of the water, within minutes, you lose that gel-like layer. That is the endothelial glycocalyx layer that is on the fish. That layer is also covers the outside of your eye, and it covers the lining of the intestines. And in every single vascule, so veins, arteries, capillaries, even the lymphatic system has a glycocalyx layer, which is right here. After you eat, you reduce the size of the layer, and it takes about 6 hours to rebuild it. If you're a diabetic, this is what you start with. If you smoke, this is what you start with. Remember, the endothelium is right here. And here's what happens. You completely lose it if you're a diabetic and you smoke. Smoking completely devastates this layer. Why? It is an inflammatory response that happens within the vasculature. We know this because we've looked at this and we've studied this. And I was part of this study, and we continue to do this, and I'm still working with this particular scientist, which I absolutely love. So we compare this layer, folks, to a pan. And I don't want to use the word because we can't use the word for the coating on the pan that allows when you cook an egg to slide right off. You know what that layer is, right? And that's exactly what this gel-like layer is. It's that coating on the pan. When you lose the coating and you cook the egg, what happens to the egg? It sticks to the pan. And that's exactly what happens here. When you lose this layer, you lose the coating on the pan, and the egg starts to stick, and this is where this is the beginning of atherogenic plaque. Now, is the plaque stable or is it unstable? You can do a calcium score. Your calcium score could be 1,000. But if your calcium score is 1,000 and it's stable plaque, if it's calcified plaque, is that dangerous? No, no. If it's unstable plaque and it's not calcified, that's when it becomes dangerous. So my thinking on this whole thing is there's inflammation going on within the vasculature for people who smoke cannabis frequently. If you're smoking, and some of the data is now suggesting this, but nobody has said anything beyond it's inflammatory. We know it's inflammatory. That's why this is happening. I am proposing that this is what's producing the damage and this is what's happening. Now, the other thing is a lot of these smokers also smoke cigarettes. A lot of these smokers are also, their diets and, you know, their diets, their lifestyles may not be the best. So now you're smoking, your diet and lifestyle is not the best. You're smoking also cigarettes. What are you doing to this layer? Is your baseline now here? And are you really destroying that whole layer and the endothelium is now being exposed? Again, this is complete speculation on my part. It is me thinking through this thing as I started to read these articles. So what we also do know is that THC binds the CB1 receptors. We all know that. And works in the human brain, heart, and the vascular system. But frequent use causes inappropriate activation of the CB1 receptors, which can cause an inflammatory response. We know that in diabetes, we see that in atherosclerosis. And this was, again, another study looking at THC exposure initiates this damaging molecular cascade in the blood vessels. But how does it do that? If that layer, if that glycocalyx layer is intact, you can't damage the blood vessels. You just can't. Because remember, the egg is just going to slide right off the pan. And there is no inflammatory response in that situation. And again, I can get into much more detail because I have a whole presentation just on the glycocalyx, which I just presented actually 2 weeks ago here in Orlando at another conference. So what this gentleman is saying is that this is not a benign drug. I don't know what that means, except to say that's his quote. So researchers analyzed genetics. And again, I also think I do a lot of genetics in my practice. I do a lot of bioidentical hormones. I do a lot of nutrients. I do a lot of supplements. And I've been doing this for a very long time, in fact, 35 years. And what I'm also seeing is genetically, and we know this, everybody's different and responds differently to various modalities and therapies. So does genetics have something to do with this? Probably. So nearly 35,000 participants reported smoking cannabis. Of those, 11,000 smoked more than once a month. This was reported in Cell, by the way, in 2022. And by the way, you want to read some good journals? Read Cell, read Scientific American, read those journals. I'm sorry, New England Journal of Medicine, JAMA, paid advertisements. That's all they are. They're paid advertisements. And I get the medical students and residents need to read this stuff. Yeah, you do. You do. You know, you got to do something for your boards. So yeah, you do. But go beyond that. Go beyond that and read real literature. Read real science, because that's where you're going to find the real science. Again, first heart attack. In the more than monthly smokers were significantly more likely than others in the study to have a heart attack. Now, here's the other interesting part. Who smokes? Who are the majority of people who smoke? Are young people. Now, yesterday, someone in the audience referred to 40s and 50s as being older. I saw that gentleman walk in and I hope he left. But the younger folks, we're starting to see disease in much younger people. And we all, again, know that. For those of you that are in clinical practice, which I know a lot of you are, we see that. Folks, don't forget that we still need to take care of people medically, okay? That's a very important people here. So in this first heart attack, we're before the age of 50. Have they and did they damage the glycocalyx to the point that it did not have time to rebuild and has devastated that endothelial layer? So again, it would be, it really acts on these receptors in the central nervous system, but frequent use is where it becomes a pro-inflammatory substance versus an anti-inflammatory substance. But here's what's also very interesting. The same effects would not were not necessarily expected with full spectrum hemp oil. Just the cannabinoids themselves with the low THC. Again, reporting data that I have seen here. So it's CBD. And when we say CBD, you know, for me, it's not just CBD. It's that entourage effect, right? It's the full spectrum of the cannabinoids. This is just a graphic of what we see and how this works. The direct effects of THC that does produce vasospasm, producing platelet aggregation. How does it produce platelet aggregation? The only way it can produce platelet aggregation in the vasculature is if you damage the glycocalyx layer. Platelets will not aggregate on the endothelial layer if you have a glycocalyx intact. It can't. It's physiologically impossible because they are just going to slide right through. The egg is going to fall right off. But if you damage the layer, the egg is going to stick, which is where I believe the platelet aggregation is happening. And where do you aggregate? Where do you activate factor 7? It's in the endothelium. It's by blood flow. It's what increases nitric oxide. It's the flow. The flow across that glycocalyx layer is what promotes and stimulates all of these anti-adherence factors themselves. So there is vascular information that produces platelet aggregation. There is endothelial irritation that produces the vasospasm. And that's what produces this whole cascade of inflammation within the vasculature. So it does produce a arteritis, vasospasms, and platelet aggregation. Not necessarily associated with ventricular. So this is interesting. Smoking marijuana may not be associated with an increased risk of ventricular fibrillation and ventricular attack following an acute MI, which is very interesting to me. And I was trying to think through that mechanism because it has nothing to do with flow. How do you get VTAC and VFib? You get VTAC and VFib a lot of times, maybe due to coronary disease, coronary spasm, but also nutrient deficiencies, magnesium, calcium, CoQ10. These all also will trigger, but what do we check if somebody comes in VFib and VTAC? Electrolytes, but we need to go way beyond that. But the study also reported that the marijuana users had a decreased risk of atrial fib while they were in the hospital post-MI, which is, again, very interesting. And I'm trying to think through that mechanism also. And this was just another study that showed basically, again, the arrhythmias, 7.6% of people had arrhythmias that have used cannabis. The average age was 50.5 years compared to 38.3 years. Again, why? Other comorbidities contributing to the 50-year-olds having a greater risk and greater damage to the glycocalyx itself and overall, perhaps poorer health. So I was involved in a study. This is a published paper, by the way. It was published in Clinics in Medicine, and I'm one of the authors in here. You can't see it, but I was involved in this study. We were looking at 150 patients, and we had them on a product, and this was a diabetes study. I wanted to see, was there going to be a decrease in hemoglobin A1C, and was it going to help people with diabetes? Because my initial theory was that diabetes is an inflammatory condition. In my mind, it's an inflammatory condition that the beta cells in the pancreas just don't work the way they should. So if I can reduce inflammation, the beta cells should work better. That was the whole thing of the way I started this. Well, in the middle of the study, a group of patients got COVID. And we said to ourselves, we got to stop the study. And somebody said, no, let's keep the study going, but let's look at what's going on in these patients with COVID. And folks, this is a very quick summary. Here's what we found. What we found was these folks that had COVID, we looked we looked at TNF alpha, we looked at IL-6, we looked at IL-1, and we looked at CRP. And again, I forgot to take this product out, but anyway, this was the placebo group here. This was the product that we used. And if you can look, and I don't have time to go through all of these, but you can look at, I mean, if you look at CRP right here, this is very dramatic. 1 week into it, with placebo, you see where we are. And 1 week into it, you can see, where we were. But in 2 weeks, look at how much of a decrease there was. In 3 weeks, look at the decrease here. So again, when we use the right stuff, if you will, we can decrease the inflammatory response and what goes on here. I'm running out of time. So in conclusion, our conclusion in this study was, this was one of the first studies that showed that using CBD hemp-based formulas in COVID-19 test positive patients, substantially evidence was there and developed a considerably higher bioavailable cannabinoid-rich formulas as a possible palliative and therapeutic option for patients with COVID-19. Why? Because it reduced the inflammation. It reduced the inflammatory response that was going on. So I hope I didn't confuse you too much. Again, the bottom line here is, why are these things happening and why does this work the way it does? And as I always finish my presentations, I was trained by the Franciscans. And for me, this is not a prayer, folks. For me, this is a way of life, doing the good things in life. And I have I have 19 seconds left, so I have 5 points of wellness. Number one, you need to take some basic nutrients. Number two, you need to fuel your engine with the right fuel. Number three, you need to balance your hormones. Number four, you need to get off of your butt and do something. And number five, you need to do one good deed a day. It's that simple. Thank you, folks, and God bless.
Well, we do have about 5 minutes before the noon hour. Does anyone have any questions for any of the panelists?
Here's the mic.
Dr. DeSilva, thank you for that presentation, because I recently had a patient who came to me with history of coronary artery disease. And she said to me that she was having an anginal attack and that she took cannabis. I'm assuming it was more CBD, and that with the cannabis, her anginal attack went away because she lowered her anxiety. She lowered her fear that she was having a heart attack. And she said that the cannabis helped her anginal pain. And I was wondering, again, how cannabis helps the heart, because I've been reading about all the deleterious effects on the heart.
Right.
But I've had patients that have said, at least a couple of patients that have said that when they were having their anginal attack, that cannabis helped reduce their anxiety.
Well,
their
I
pain.
think what you have to define here is it anxiety or is it actual chest pain? Are they having angina? And I think a lot of times people just get so nervous and they get so anxious. They say, oh my God, I'm having chest pain. Okay. Well, the thing I worry about is you cry wolf too often and you're going to get into trouble. So my first thing that I would say to them is, if you have known coronary disease, take the sublingual nitroglycerin. If you have no known coronary disease, i.e. you've had a stress test, you've had perhaps a cardiac cath, and you have no coronary disease, fine. Use the cannabis. I have no problem with that. But if you've got known coronary disease, you need to use a sublingual nitroglycerin first.
For Dr. Silva, thank you, everyone. Quick question. You started the study on diabetes. You completed it as a COVID study. What were your results with diabetes?
By the way, the hemoglobin A1Cs came down significantly. It was statistically significant, the A1Cs that did come down. 90 days study. It was a 90-day study. Yes, Matt? Or was it, it was 90 days. Yeah, it was 90 days. And then we extended it out to 6 months.
I got a couple questions. How would we measure the endocannabinoid system? Is it through anandamide? Are you measuring anandamide to understand the depletion of?
Yeah, so the study I was referencing was by Dr. Russo, and it looked at CSF levels of anandamide. I can give you that reference.
And as far as the juvenile brain, how do you explain the endocannabinoid receptors existing on the placenta?
How do you explain?
The endocannabinoid receptors, CB1, CB2, CB3 on the placenta.
Well, there are much more than just the central nervous system in an adult. So, there's interactions with the cardiovascular system, with the gastrointestinal system. We just focus on the brain when we talk about CB1, CB2, because most of the time we're treating either a neurologic condition or a pain condition, but they are all over the body. And if you look at and think about the side effect of weight gain, look at Snoop Dogg, look at Wiz Khalifa, what's their body habitus? And I can't think of anybody that consumes more cannabis than them two. Yeah. So it is all over our bodies. And that's another, actually, a lead, when you think of the mechanism, that's how we get a lot of the side benefits. We don't really talk as much with our patients about side effects like we do with gabapentin, Narantins, and Volta. You hear more stories of side benefits. You'll ask about side effects, but you'll hear more stories of side benefits. And that's actually one of the reasons why you see that.
Is there a correlation between the Tax Act of 37 and the increase in autism?
Is there a correlation between
The Tax Act of 1937.
the Tax Act?
The
Okay,
Marijuana Tax Act of 1937 that put hemp out of business, and the increase in autism over that similar period of time.
I don't know. I'm not a tax specialist, and I'm not an
I'm just
autism
talking about the
specialist either.
Marijuana Act of 1937.
Yeah, I'm not sure. Actually would be, maybe you and Dr. Trout could get together at the end. He is actually a specialist on cannabinoid applications for autism patients, and he's a cannabis historian as well.
Thank you all for your wonderful presentations. They were all really good. I have a couple of questions. One for Dr. DeSilva. When you were presenting the information on the heart with THC and smoking, I tell a lot of my patients, if they want to use flower, use a dry herb vaporizer because of the combustion byproducts. Do you think that the endothelial layer that's being depleted there is because of combustion heat? And if maybe they were to consume their flower at a lower heat, which is what dry herb vaporizers do, would that maybe protect the endothelial layer? And then do you also think that using a different route of delivery like edibles should be fine for the heart?
That's a great question. And the answer, I'm speculating on the answer. I'm going to speculate on the heat. I think any kind of vape, any kind of vapor, any kind of inhaled compound is going to damage that layer to some degree. Again, that is speculation. As far as the temperature itself, I don't think it makes a difference. I really think, and perhaps Dr. Noe can even jump in here, but I don't think that has an effect. Would I prefer edibles? Yes, because I don't know that anybody's really looked. And that's the other thing that they have to differentiate here is, what about people who used edibles? Did they have a greater risk than people who smoked? So those are, that's where I would go with that.
Thank you. And then I have one more question, Dr. Newton, about the terpenes. There is a challenge with some of the dispensaries that they don't always give you the full terpene profile. So I tell my patients, instead of looking at sativas and indicas, look at the terpene profiles when you're trying to choose your flower strains, but we don't always get the full terpene profile.
Yeah, one of the challenging things about, let's say, an individual plant is that if we follow a plant and we test it over the course of a year, over the course of 2 years, the profile of that plant can change over time. So you could test that same plant 3 months into when it was planted and test it again another 3 months later. The profiles of cannabinoids and terpenes can be different and vary.
Just a follow-up question. You said it's the THC. It didn't seem that there was differentiation of whether you smoked it or, because you were saying it's the THC that damages the vascular. And then the question is that a total amount, or has anybody looked if you use ratio products, does CBD help protect the vascular system?
Great question. And I don't think that the researchers are that smart. I really don't. You know, I don't think, see, here's the other thing that I get worried about when it comes to research and publications. People do research, and this is excluding somebody like this young lady sitting up here with, and I call her young because everybody's young compared to me anymore. But
apparently I'm old, I'm 50.
oh
so-
God,
Oh.
you're way over the hill. Okay, so, but you know, you look at, for example, you look at the vitamin E data. Vitamin E has been reported to be a pro-inflammatory substance. Well, the idiots that did the study were using D-alpha tocopherol, and then they said, oh no, there might be something else. Let's use DL-alpha tocopherol. Well, the DL-alpha tocopherol is a synthetic formulation that is 36% less bioavailable. There are 8 different forms of vitamin E, 4 tocopherols and 4 tocotrienols. That's what you need to study. And I think the same thing goes for cannabis. The designs are poor. I don't think they've delineated exactly what the factors are. And I'm presenting some very, very preliminary data here. I think the studies need to be designed better by people who understand and know this topic. I don't think these people know the topic. They were, you know, let's just study it.
May I make a
That-
comment on
sure.
that follow-up? I think this just really lends to some of what our Dr. DeSilva was talking about. When we talk about combining Eastern and Western medicine, we have this habit in Western medicine to pull everything apart and make it a drug that's synthetic. And now we have a whole different substance that was naturally intended. And I think that when we look at studies that are pure THC, pure CBD, whatever synthetic, what we're really doing is trying to find out these individual answers in terms of science, right? We have the scientific method, so we have no choice but to try to limit the variables. And so to me, that is part of the challenge when you look at, you know, just pulling THC out and doing these studies. I mean, there's a reason why Marinol has been around for decades and most people don't even know about it because it's a synthetic drug that has such terrible side effects. So when we look at pulling this apart for the sake of research, I think we lose some of the, you know, we throw out the baby with the bathwater in that regard. And so when we look at things like smoking, for example, I mean, that high heat going into our lungs, you know, absolutely is not something we were naturally made to do. Okay. Is this why thousands of years ago, people only lived till, you know, 35? Were they having heart attacks from using too much ganja? I don't know. The point is that every time we look at doing something that evolutionarily our body is not really designed to do, we're going to have an effect. And that involves pulling out these individual chemicals that, of course, pharma is going to jump on and make these drugs, right? And we're trying to find the science to be able to base that on. So that's what my comment is with regards to these things. You know, when we look at substances in science, we have to look at what are we doing naturally and what are we doing synthetically and how that's actually affecting our body overall.
Thank you. Gee.
All right, folks, we're getting ready to wrap this up because I know everybody, we got a lunch here. You wanted to make one quick comment before we.
Actually, it ties together what you were saying and a great segue to lunch. The comment about terpene, the fact that still trying to follow the way people are using it with how popular smoking and now vaping are, those certificate of analysis about terpenes being bioactive chemicals are missing from the information we have as physicians to understand the full effect and what's causing what.
Yep.
So as we go to lunch, I just want you to know and think about it this way. You need to know what it is. It's not a secret sauce, is it? You know, like a burger comes with a secret sauce. So please let your legislators, as your individual representatives or senators, know But yeah, there's a cost basis to it, but for us to really know what we're working with why people are using smoking as a delivery. Dr. Newton up there's an anesthesiologist I got. It's the fastest way to the brain. It's not that hard to figure out why people prefer that inhalation route. But secret sauces don't make it in my formulary.
Folks, just as a real quick reminder, and Gina, what room is that in?
We're in signature 2, upstairs, up the escalators.
Signature 2. So just a quick brief. How many of you own a business in here? Okay. How many of you have protected your assets? How many of you think you've protected your assets? You haven't. After you hear this presentation at lunch, believe me, I was floored when I heard this presentation, and I've heard it twice now. And by the way, come upstairs, and this is not my company. I just like these guys, just so that you know. It's a free lunch up there, and listen to what they have to say. Will blow your mind. Thank you very much, by the way.
Thank you.
Sure.